At this time, I would like to thank all of our joining attendees for coming into the next session, where we will have a panel discussion with wonderful individuals. Please feel free to be as engaged as possible. We'll discuss the challenges and the legal implications of misinformation and health disparities in health policies in the United States. If you heard our keynote speaker, I know you already have questions and thoughts, and you might feel inspired, as I do myself. Today on our panel, we'll be joined by three particular individuals. First, Yael Cannon, who's an associate professor of law at Georgetown University Law Center. We'll be joined by Dr. Jessica Jaiswal, who's also an assistant professor in the Department of Health Science at the University of Alabama, and Aaron Schwid, who's an international human rights attorney and the director of public health at Vital Strategies. They each will take the time to discuss some of their work and what they've learned so far and continue to learn, and ask that you stay engaged and you ask questions, and we'll discuss with them individually. We will start off this panel discussion with Yael Cannon.
Thank you so much, Imani. You have done amazing moderating, and I really appreciate it. Thank you also to the Lewis Stokes Health Sciences Library and the Vernon E. Jordan Jr. Law Library, and to the amazing librarians who organized this event, and to my co-panelists who, just from our interaction so far, I've learned so much from. I want to start off by actually telling you a story, because my work is very much based in our local Howard and Georgetown communities in Washington, D.C., and in surrounding neighborhoods. And I want to talk about a family I'm going to call the Brent family. A few years ago, this family walked into a health clinic called the Hoya Clinic, which is a free health clinic run by Georgetown's medical school out of a DC homeless shelter. And this family had been evicted from their apartment, and the family of 5 had been homeless for about 2 years. They needed help overcoming housing discrimination so that they could actually get out of the shelter and rent an apartment using their housing voucher in Washington, D.C. That health clinic has a medical legal partnership with our Georgetown law clinics. So we have trained the doctors and the medical students to screen for legal needs that implicate health and refer those cases to our legal team. So the Brent family walked into the health clinic at the homeless shelter that day, and they got a legal checkup at the doctor's office. They were asked about legal needs related to housing, food and income insecurity, health insurance, and their children's educational needs. And the physicians learned about the housing discrimination that they were experiencing and referred the family to our Health Justice Alliance team. Our med and law students worked together to fight the housing discrimination through a civil rights case and help the family secure housing. And they were doing great. And then came COVID. And the Washington, D.C. neighborhood that they live in has been ravaged by the pandemic. Mr. Brent lost his job. The kids were hungry, and the Brents could not make their rent. And they knew what it meant to be evicted, and they knew what it meant to be homeless, and they were terrified of that happening again. The parents began skipping meals so that they could focus on just using their money to feed the kids. And the doctors were worried because they know that eviction, homelessness, and food insecurity are all linked to poor health. So before I tell you what happened to the Brents, I want to set the scene in their neighborhood for you here in DC. And many of you may know that disparities exist in life expectancy across our region, but also right within our city, within our fairly small city within a few square miles. And so you could take the metro from the sort of far northwest side of the city and take the metro train down to the bottom southeast corner of Washington, D.C. And just in a short train ride, the life expectancy of people in those neighborhoods would be 15 years shorter for the residents in Ward 8 in Southeast DC, where the Brent family lives, than for residents of the city's highest income, predominantly white ward, Ward 3. Ward 8 in Southeast DC is also very high poverty and over 90% African American. So when we look at this incredible disparity of 15 years in life expectancy and ask why, it really comes down to the social determinants of health. Where we live, work, eat, play, learn, and age has a huge impact on our health. And research shows actually that as much as 80% of our health is driven not by our biology or the care we get when we go to the doctor, but by these social conditions. And we can see that starkly in DC's Ward 8 and also neighboring Ward 7, east of the Anacostia River. We can see poor housing conditions. We can see high employment, food insecurity and food deserts, medical deserts, lower quality education, and chronic stress, all of which are known to harm health. When it comes to COVID, Ward 8 has 11% of DC's residents, but more than 20% of our city's COVID deaths. And these same social determinants of health, we can see how they have contributed during COVID. So Ward 8 has more essential workers. People in that neighborhood have had to go to work throughout the pandemic, and many of them have not been able to work from home. There is a reliance on public transportation for work and for school. It often requires multiple bus rides on public transportation to get to a grocery store because there are so few in the neighborhood where the Brent family lives. It is more difficult to socially distance in some of those higher density neighborhoods and apartment buildings. And it's important to note that COVID deaths and the other poor health outcomes that we have seen during COVID and long before, as our keynote speaker discussed as well, persist across socioeconomic status in DC and across the country, making it clear that it's not just a function of poverty, but clearly a function of structural racism as well. And many families like the Brent family are really faced with what the public health literature talks about as that sort of double burden or double jeopardy faced by people of color who are also living in poverty and face that oppression and marginalization on multiple levels. And so the disparities in our city are really a grave injustice. They're driven by social conditions that are no accident. And I have researched and written about the idea that health justice, it's racial justice, it's economic justice, it's social justice, and it's environmental justice. And COVID has exposed these longstanding disparities and the role of social determinants of health in driving them, and it has also exacerbated them. And it turns out that really we have to acknowledge that injustice itself is an underlying condition. And this is the information that we need to get out there because it doesn't have to be this way. Law and policy can do something about it, which is kind of the hopeful news that I want us to think about. So there's a growing body of scholarship and activism in the field of health justice, which is really a movement to leverage law and policy to eliminate health disparities and promote a world in which all people have an equal chance to achieve health. Right now, we see what a huge role a person's zip code, for example, has in driving their health, and health justice aims to change that. It's really intentional that the health justice framework uses the word justice, building on the ideas that people have written and thought about for a long time around health equity, but adding the word justice requires us to really acknowledge that law and policy have very intentionally, by design and driven by structural racism, caused many of these disparities. And in our city, we see that both historically and present day, with the legacy of redlining and restrictive covenants and zoning policies that have allowed highways to cut through neighborhoods, and also gentrification that has exacerbated segregation in our city. We see it with those food and medical deserts, right in the middle of our very well-resourced nation's capital. But in addition to sort of examining these injustices and the role that law and policy can play, health justice also requires us to remedy them. And I think this symposium is so great in bringing people from the legal field and the health fields together, because I think professionals and advocates and students and scholars in our field and in related fields, we can make a difference in shaping law and policy to address disparities, and also thinking about what existing legal rights there are that can be enforced to that end. So I want to end by kind of talking a little bit more about what that looks like. So just to come full circle first with the Brent family, and then we'll kind of build out what next steps might look like. So with the Brent family, our Health Justice Alliance law and medical students really came together to advocate to appeal the denial of unemployment benefits that was wrongly given to the father in this family, to advocate for higher food stamps because with their decrease in income, they were actually entitled to more. And to help the family understand and assert their rights under DC's eviction moratorium. And with that advocacy in place, the family was no longer hungry with that increase in income and food stamps. They were able to avoid eviction. And this is really the medical legal partnership model at play. And I'm happy to talk more in the Q&A or offline with anybody who's interested in learning more about that model. But just quickly, we work with low barrier access to healthcare models, such as the Hoya Clinic I talked about that's based in homeless shelters, such as Georgetown Community Pediatrics Kids Mobile Medical Clinic, which is a pediatric mobile van, a pediatric office on wheels that parks in public housing complexes and other low-income neighborhoods in DC that are pediatric medical deserts, so that kids can just walk right out their front door and get medical care. And we also work with 2 school health centers at 2 high schools in DC where the families are often under-resourced, and that's Anacostia High School and Roosevelt High School. And so when families come in to get healthcare to those low barrier healthcare clinics, they're also provided with low barrier access to justice. And so those families get a legal checkup when they're in there, and then our law and medical students advocate in collaboration with our other healthcare partners to address their needs. So zooming back out, how do we take action together to pursue health justice? So I think it starts with making sure that the information is out there, that health disparities, like our keynote speaker talked about, are examined and understood, that the role of law and policy in driving those underlying social determinants of health is widely understood. I think this really needs to be part of the national conversation around health, not just what healthcare can look like, but how we really get at the social determinants of health to address those. We also have to ensure that the role of structural racism in those laws and policies is closely examined and named explicitly. And once we have that basic understanding, it's time to take action. And some of the ways that we can do that is to enforce laws for which under enforcement is actually driving disparities, laws that are really meant to or can have the impact of protecting health, particularly for those who are more marginalized. We can ensure systemic reform by getting rid of bad laws, reforming them, creating new laws. And we can also partner with individuals and grassroots organizations from affected communities, those communities that have been subordinated and oppressed, to support them in achieving more structural reform. And so I'm going to talk before I wrap up about what that might look like by telling the story of one more family. And I'm going to call them, for purposes of this talk and for anonymity, I'm going to call them the Cooper family. And so the Cooper family came into the kids mobile medical clinic, that pediatric van on wheels, to get one of the health checkups that they needed for the kids, and they also got a legal checkup when they were there. And those checkups revealed that one of the children in the family had been severely lead poisoned in her home. and was experiencing developmental and educational delays as a result of that lead poisoning. And you may be familiar, with the crisis in Flint, Michigan, where there were high levels of lead in the water. We have high levels of lead in Washington, D.C., sometimes in the water, but quite often in the paint, in homes where low-income families live in fairly poor and dilapidated housing stock in our city. And when the doctors talked more with this family and gave this kind of legal checkup, they also learned that the child's Medicaid had been terminated and treatment was going to be more difficult for her to access that she really needed for that lead poisoning without health insurance. So the students got to work on enforcing the laws we have on the books to ensure better health for the family. So they advocated for remediation of the lead to be done to make the home safe where the family was living. They advocated to restore the child's Medicaid. They obtained comprehensive educational and developmental evaluations and advocated for really robust special education services to allow the child to really thrive in school. And then our law and med students spend some time really wrestling with these issues back in the classroom at Georgetown to really explore the why behind the family's story. So the role of structural racism in redlining and restrictive covenants and gentrification and zoning laws and other laws and policies that have segregated Black families in our city into those neighborhoods with poor housing stock. And have made it so that we don't have robust prevention and enforcement mechanisms to ensure that people in that housing are safe. And then our students also engaged in systemic reform. They advocated for a bill that came before the council, our DC council, our legislator, to really strengthen lead prevention and enforcement laws. And that bill is still in progress. And if it passes, it will be one of the most, or perhaps the most sort of progressive and robust lead prevention and enforcement laws in residential housing in the country. And I think the students grew to appreciate from their professional training and the community-based partnerships that they were working within, that they could identify by working out in the community gaps, patterns, and problems with the law, and pursue reforms that would help to advance health justice more structurally. Perhaps most importantly, they also partnered with the child's mother, who was our client, to support her in her own broader pursuits of health justice. She wanted to make sure that other children in the city don't experience what her child did. And so our students prepared her to testify, supported her as she walked into the DC Council building for the first time in her life to testify on these issues as well. And I think the students saw how, as law and healthcare professionals, we can also step aside and play a supporting role in letting individuals, grassroots organizations, and communities really lead on these issues and how we can learn from them. And I just want to end by saying that I'm so privileged to be part of a partnership between law and medical and nursing schools. And I really see an opportunity where those of us at schools of law and medicine and nursing and other academic institutions who are training the next generation of lawyers, of policy advocates, of policymakers, judges, of doctors, nurses, and other health professionals, I think we have a special responsibility to equip our students with this knowledge, to get out this information about disparities, but also about where they come from, of the role of law and policy in creating social determinants, of the role of structural racism in driving these disparities. And I think we can also equip our students with skills, with the skills and values they need to actually act to ensure health justice. Thank you so much for your time, and I really look forward to engaging with you, Amani, and any questions you or others might have.
Well, Professor Cannon, I cannot thank you enough. I really enjoyed that discussion. And like you said, you have a very special placement, having access to both the medical legal partnership that we find with the Health Justice Alliance. And so at this time, if any audience members have questions, feel free to drop them in the chat, but I'll start off with mine. As a law school student, I am curious to hear about the training, specifically what tools have you seen over and over again that is essential for young student attorneys and for young attorneys in helping to ameliorate some of the health disparities found by their clients?
Such a great question, Imani. Thank you so much. I think that one of the most important things that our students learn to do is to listen. And one of the skills that crosses both legal and medical training is interviewing. And our students spend time in the classroom together, and they kind of bring the best of what each of our disciplines and the research around interviewing has to offer to really learn what it means to listen actively, to listen empathetically, to open their minds and learn to realize that at the heart of all we're doing is our clients and our patients, and the goals and wishes and hopes that they have for themselves, and to put them at the center of all we do so that they can lead. Because in the end, I think that's how we are really going to get at the roots of these disparities, is by listening and by thinking very humbly about how our professions can really play a supportive role.
I think that is a very great piece of advice for those who are interested in whether going into the medical side or the legal side, just really listening and embedding yourself in what your clients are bringing to you. And that leads me to my next question, which really centers around the information and taking action together. For those who are on the call today, we have professionals, we have students, we have law school students, we have graduate students of different sorts. What can we all do today that might support the Health Justice Alliance, or really just the dissemination of information?
Yeah, that is a great question. Well, we, I hope in better times can welcome you over to not only to the law and medical schools at Georgetown, but into our community-based partners, and to have you come and see the kids mobile medical van in action when it parks in different neighborhoods. And we have lots of opportunities to get involved and volunteer with our work and to engage in some of the research. We've worked with students from many other universities and medical and law schools around research that we've been doing at the intersection of criminal justice and health, and education and health. Up at Washington Hospital Center in Washington, DC, we have a project on perinatal health, looking at the really grave maternal and infant health disparities we have in Washington, DC, which I know has been a priority of Howard University to play a leading role in addressing those. And we have lawyers embedded at the hospital, at Washington Hospital Center in labor and delivery, working on those issues. And so we would welcome our friends at Howard and anyone else who would love to partner with us. But I think another suggestion that I guess I would have for getting involved is to really look locally. There's a lot of action happening, of course, at the congressional level on some of these issues, and there's a bill that's been reintroduced in this Congress to study through the CDC more deeply social determinants of health and to address these issues legislatively. And so there's ways to get involved in supporting federal legislation, but there's a lot more action and movement more quickly, as you can imagine, at the local level. And for example, one big issue happening right now is that we are going to be seeing the end of our eviction moratorium in DC in the coming months. And there's a huge effort to get out emergency rental relief assistance that will go far in preventing families from becoming homeless and prevent all of the many, many poor health and mental health outcomes that we know are associated with eviction. And so there's lots of ways for law and medical students to get the word out. We have flyers I'm happy to share with anybody, that you can share with clients and patients that you're serving, to tell them about how to access the emergency rental relief funds. The city is really trying to get the word out, and there's lots of ways to get involved.
Thank you so much, Professor Cannon. I really appreciate, as I always say, the transparency around the information, and that's what we're doing today, making sure that we have clear information and access. And I thank you for all the work that the Health Justice Alliance is doing. At this time, we will prepare to shift to our next speaker on our panel, who is equally as exciting and has as much information to provide, Dr. Jessica Jaiswal, who is going to speak and currently is an assistant professor in the Department of Health Science at the University of Alabama.
Hi, everyone. I want to echo Professor Cannon's thank you for having this wonderful, and unfortunately very timely symposium. I am a public health scientist with training in medical sociology, so I'm not a lawyer, but it's been really amazing just, briefly speaking with the other panelists, and for me to see just the amazing reach that law can have. So in public health, we really take a structural look at health inequalities. And so, we're always trying to push us to look not only at the individual level, but all the different ways in which structure and policy come into play. So just throwing it out there, a lot of law schools have dual MPH JD programs. So maybe for students who are interested in both health and law school, maybe you could look into that. So today I'm going to be, just checking the time, I'm going to be talking about medical mistrust, misinformation, and disinformation. And specifically, I guess more than anything, trying to give us food for thought. So as I said, I'm a medical sociologist, so I'm really always thinking about social structures. And today I hope to have us delve into really trying to nail down and articulate what is mistrust and disinformation and misinformation, and really try to nail down all the phenomena around all of the types of misinformation and disinformation that we've seen during the pandemic, and then hopefully starting a discussion about what do we need to know or what do we need to understand to move forward constructively. So briefly, misinformation, just throwing out some definitions so we can get on the same page. Misinformation being false information that's not necessarily spread with bad intentions, which is a little bit distinct from disinformation, which can be understood as strategically and deliberately spread false information. And this is important because when we're thinking about disinformation, I want us to focus on how during the pandemic, disinformation has been spread by not only the government and other sort of federal institutions, but also other people and groups in positions of power. And one way to think about disinformation is that it reflects anxieties around loss of power. So again, putting on our sociological hats, thinking about power in society. So just briefly touching on the pandemic inequities that unfortunately, I'm sure we're all very familiar with, but we do know that minoritized communities have been disproportionately affected by COVID-19, especially in the beginning of the pandemic, but still now we see quite a lot of blaming. And so like, for example, and again, especially in the beginning, there was a lot of talk around, oh, well, Black communities and other communities of color are disproportionately negatively affected by COVID because of underlying conditions. And then the analysis would stop there rather than, as Professor Cannon was talking about, really honing in on the social determinants of health and asking ourselves, why do some populations have more underlying conditions than others? Similarly, with this whole idea of vaccine hesitancy, it's been used in some ways to, again, blame minoritized communities for having low vaccination rates without enough discussion around the fact that availability does not equal access. Even nearly not quite 2 years into the pandemic, availability does not equal access. And so throughout the pandemic, we have seen time and time again that misinformation and disinformation has had immediate, very tangible consequences. And so if we step back for a moment, the beginning of the pandemic, we had a knowledge vacuum. We didn't know a lot. There were so many unknowns. So that, of course, caused a lot of fear and anxiety, uncertainty. And then also with the fact that scientific knowledge develops over time. So when we learn new things, we change or modify policies and recommendations, which has not gone over that well, which I think really points to the need for public health and medicine to be introspective about how we were communicating science. But for example, perhaps you have people in your life that were frustrated by, first Dr. Fauci said no masks, and then he said masks, and then he said no masks. So what am I supposed to believe? I can't trust these official sources of information. But it's important to note that minoritized communities have also been deliberately targeted for disinformation campaigns. So right there, we have a differential access to trusted information. So for example, prominent, well-funded anti-vaccination organizations have targeted Black communities and have cast doubt on the safety of the vaccine by evoking images of the Tuskegee study. So really evoking powerful, violent imagery, to make their point that in their view, the vaccine is dangerous. And we've also seen some of these groups who are propagating disinformation specifically target Black communities, and they evoke the also powerful imagery of Black Lives Matters. So I want to take a few moments to talk about what medical mistrust is, because it's a phrase that, or it's a term that we've really have seen floating around more, just like conspiracy beliefs, which I'll talk about in a moment. But I think it is important to take a moment and try to nail down what it is and isn't. So medical mistrust is often implicitly defined as lack of trust. But I want to point out that mistrust is not the same as lack of trust. So mistrust is better defined as suspicion of bad intentions. So it's not just that I have a lack of trust, but that I think that you are going to do something against my well-being. And medical mistrust is also often implicitly defined as a lack of trust in healthcare providers. And while that can certainly be part of it, again, putting on the public health sociology hat, we really want to be talking about the structural and institutional aspects of mistrust. So here I'm talking about the government, the pharmaceutical industry, the carceral system, the healthcare system, which includes, insurance companies, hospital systems. So really zooming out from just individual healthcare providers, but looking at the way all of these systems interact to oppress some people and lift up others. Historically, medical mistrust research has focused mostly on Black populations and other racial and ethnically minoritized populations. And as previous speakers have talked about during the symposium, it's often linked to the Tuskegee study, which of course is one of the most absolutely egregious examples of public health and medicine's, just betrayal of trust. But it's important to note that the oppression and the socioeconomic marginalization is both historic, but it's also ongoing. It's people's daily lived experiences of being socially and economically excluded or oppressed. Another aspect of medical mistrust that I want to touch on is you might hear medical mistrust being referred to as a cultural barrier. And I just want to put a full stop to that, because especially when we use that phrase cultural barrier to talk about the mistrust that, for example, Black communities have. It really puts the onus on the community for having this sort of these paranoid ideas, or it puts the blame on the communities rather than asking the question, why do these communities distrust, for example, the healthcare system or the federal government? And so when we move away from an individual level understanding of mistrust and look at it as a structural phenomenon, we can hopefully start to see how it's a constellation of systems and institutions that create, sustain, and reinforce racism, classism, stigma, homophobia, transphobia, all of those things, other forms of structural oppression. Still throwing out some more definitions for food for thought is another phrase we've been hearing a whole bunch is conspiracy belief or conspiracy theory. I wanted to spend some time on this because when we, especially for those of us, in the health field in some way or another, have been so incredibly devastated, disappointed, enraged, resentful, all of the emotions about how the pandemic has been handled at both the federal and state levels. And I think there's some value in trying to understand why, quote, conspiracy beliefs are so incredibly durable. And so we can think of conspiracy beliefs as a type of mistrust. And a conspiracy belief typically highlights a power differential, and it's typically talking about some kind of secret plot to accomplish some typically malicious goal. And they have a very durable nature. They're extremely hard to disprove. New evidence is rationalized into the existing narrative. And so that means that whatever, perhaps if you've been in an argument with someone and you present some facts and they can either accept or deny those facts, but let's say they accept them, they can rationalize that and say, well, that's actually evidence of how X, Y, and Z. So it doesn't necessarily mean that the argument is debunked. Like you'll hear that language a lot, like we need to debunk these myths. It's very hard to do so because any new evidence is just absorbed into the narrative. And then also about conspiracy beliefs is throughout history, and they exist in all cultures, around the world. So as long as there's been humans, there have been conspiracy beliefs, and they're not always false. So, this gets into kind of a tricky territory because there might be aspects of an idea that have some kernels of truth, either from the outset, or we find out along the way that, there was this one aspect that was true. And that makes it also very resistant to debunking, so to speak. And they also, conspiracy beliefs also really just highlight chaos, anxiety, social instability, disempowerment, which I think we've all have really seen play out during the pandemic. And health-related conspiracy beliefs in particular are really common. So for example, an MMR vaccine causes autism. I'm sure many of us have heard that. My area of research is actually around HIV and HIV-related mistrust. So a very common idea that lots of folks hold is this idea that HIV was created by the government to kill Black people. Which I want to point out, these ideas are often called crazy or paranoid, but in the case of this idea, for example, that HIV was created by the government to kill Black people, people have really great solid reasons for believing that. And I think instead of dismissing them as paranoid or as a cultural barrier, we need to really understand where people are coming from. So all of that to say, going through all of those definitions and conceptualizations, I've been trying to make the argument that So during the COVID pandemic, we've had a lot of ideas and quote conspiracy beliefs, unquote. For example, the vaccine has a chip in it, or just even, the vaccine doesn't work, or the vaccine is experimental and they want to experiment on you and you're a guinea pig. What we've seen is really sociodemographically diverse groups come to the same conclusion. And I think we should spend some time thinking about how we all get here, because on one hand, we have what I think of as inequality-driven mistrust. So inequality-driven mistrust is mistrust fueled by not only historical legacies, but also ongoing injustice and lived experiences of inequality. And it's likely a worldview that spans more than just a belief about vaccines or COVID. So again, zooming out, inequality-driven mistrust likely exists before even someone starts thinking about what they believe about a vaccine. And then this mistrust is further justified by the extremely racist, xenophobic, and ableist response we've had to the pandemic. And I think that overall, the takeaway is that inequality-driven mistrust really is evidence of the failures of our institutions, of the government, of public health and medicine. In contrast to disinformed denialism, or what I'm thinking of in my head as disinformed denialism. So as I said a few minutes ago, there's been really common popular ideas and beliefs during the pandemic that have emerged around, that it was a planned pandemic, or the vaccine is not what they say it is, or, there's countless of these types of ideas. And we've had people from all different sociodemographic backgrounds come to the same conclusion, which has been interesting and odd, because typically we would think of these various groups of having a little bit less in common. And so when I think about disinformed denialism, and here I am also, what's also coming to mind is the recent Kaiser report talking about subgroups of folks who are planning to not get vaccinated. And on one hand, you had a group that they characterized as wait and see, and those were populations of color. And then you had another group of holdouts who they described as being predominantly white, evangelical, and politically conservative. And so here we have communities that have been historically and presently minoritized and marginalized, with other groups that have enjoyed being the dominant group. And so here I think of disinformed denialism as seeking to preserve the power of dominant groups. And this is where I think a conversation about nationalism, about white supremacy and capitalism, and how those are conflated with patriotism. And I think another, or perhaps one of the most important points for me, is that during the pandemic, we had disinformation institutionalized under the Trump administration. So it wasn't that there were fringe groups or fringe publications that were propagating these types of ideas. Rather, they were literally institutionalized at the federal level. And in a lot of ways, one way to think about it is that President Trump legitimized white supremacy, and he put forth this idea that white people are both the victims of these various plots, but they're also the victors, and they are the rightful true Americans. And I think that's something that we really have to grapple with. So we've seen that this COVID-related disinformation is fueling misinformation among minoritized groups, as well as these more socially dominant groups. So, these shared ideas about COVID isn't real, or the government is lying about COVID, like, what do we do with that? parsing of inequality-driven mistrust versus disinformed denialism is not a perfect binary, and it's not meant to kind of use to like neatly categorize, but rather to get us thinking about the iteology of where these ideas come from and how people arrive at them. And so this is important for public health messaging. You know, I've seen so much, and maybe you all have, have also seen, you know, stuff like COVIDiots, pandemic of the stupid, and, you know, all the different ways that that many of us are rightfully expressing just our rage and disappointment, and, you know, all the feelings about how poorly this has gone, and also how much preventable death we've had. But I kind of want us to take a step back and think about, okay, how do these different groups get to these ideas? Because it matters. It matters in how we tailor messaging. So calling people stupid, ignorant, I totally understand the underlying rage as a public health professional. You know, truthfully, watching the pandemic unfold has been a very special type of hell, to be honest. And so I totally get that. But as folks who I'm guessing are on this call because they care about humanity and they want our society to go in a better direction, I think we do have to reckon with not only trying to understand where people are coming from, but also reckoning with white supremacy. So here I'm going to argue that mistrust on the part of minoritized communities and mistrust on the part of, for example, the Kaiser reports folks who are described as being primarily white, evangelical, and politically conservative. Both types of mistrust can bring us to the same types of ideas. For example, government's lying, the vaccine isn't what they say it is. But we have to reckon with white supremacy to deal with any of these ideas. I don't think it's enough to talk about racism. Talking about structural racism definitely gets us closer, and talking about anti-Black racism gets us even closer. But I think this is one instance where centering white people is in fact quite appropriate, and we have to have that discussion about white supremacy. In just a minute or two I have left, I hope I'm not going over. White supremacy is not a shark, it is the water. That's a quote by the poet Wanta. Again, white supremacy is not a shark, it is the water. So white supremacy is not only the KKK, it's not only Confederate flags, slavery, racial slurs, or even the January 6th insurrectionists, or outlandish and derogatory politicians and media personalities. Rather, white supremacy is an all-encompassing constellation of systems that structure the environments in which people make decisions about their health. So access to material resources, access to affordable, high-quality healthcare, access to trusted sources of information and education, standards of beauty, speech, professionalism, and access to dignity, respect, compassion, benefit of the doubt, and social inclusion. And so to close, I want to note that white supremacy does not require an abundance of outwardly racist individuals because it relies on systems. So we must render visible whiteness, white supremacy, and its effects on both communities of color and white communities. And I think this is all to say that, you know, public health and medicine have been saying for a long time, trust science, trust science. And I think we are at a point where we have to admit that that's not going to be enough to persuade people. And particularly talking about minoritized groups, by and large, that trust has not been earned. So in order to deal with misinformation and disinformation, I do think that we need to reckon with white supremacy.
Well, Dr. Jaiswal, I just want to thank you so much because your conversation tackled so many different realities that make up where we are today with misinformation and mistrust. And you had started the conversation saying, you know, as someone who's not an attorney, you just brought another element into today's discussions and all that I've heard. I will say that 2 questions that were asked, you actually answered in part. And so I'm going to work to personalize those questions before we move to our next speaker. But first, I wanted to know, how exactly can lawyers and physicians and sociologists work with technology companies in this mistrust and misinformation?
Oh, I feel like I'm not qualified to answer, sort of the tech media aspects, but yeah, if the other panelists want to chime in, I mean, really around tech, I mean, that's such one thing that has been really scary is for every piece of trusted information that public health officials put out, 3 pop up in its place that have really slick graphics and, very persuasive podcasts, so there's just, it feels very much like a war. And to be honest, it does feel like we're losing because the messaging, the disinformation messaging can be extremely persuasive and extremely just professionally put out. And I think that is very scary.
No, I completely agree. I think that's part of what led to the question. There's so much that people see and that algorithms kind of tailor for them to see that it can be very difficult. So there were 2 questions that were asked. One was around how to regain the trust, but you began to talk about that. And there was another question about how to interact with people who do believe that the government is experimenting on people. So I just want to take those and make them a little bit more personal before we move on. How do you think that we as individuals can help in one-on-one conversations with people who are not interested in being vaccinated? How can we engage with them? You discussed earlier being understanding, right? And really hearing their thoughts and concerns. One person said, I have close friends who refuse to get vaccinated because they think that the government is experimenting on people, despite all of the legitimate health and medical literature. How would you recommend for our audience member they navigate those conversations?
That's truly the $1 million question. And I think Professor Cannon said it perfectly about listening. So, on one hand, the government has experimented on people. So a lot of these ideas, not all certainly, but many of the ideas are founded in very valid historical and ongoing things that happen or keep happening. So I'm a qualitative researcher. And so a big part of my work is really giving people space to put their experiences in their own words. And in that, I acknowledge that they're the expert in their own lives. And I think medical providers should also take this approach that people, patients, clients are the experts in their own lives. I was recently just talking to a student about their anti-mask and anti-vaccination stance. And I told them from the outset, okay, I'm not here to change your mind. I just want to hear where you're coming from. Because again, I'm seeing so much rage and which I truly get, calling people stupid and backwards and ignorant. And that's just not going to get us anywhere. And so by listening is, I think, a first step, and you may not be able to change someone's mind. And maybe you don't even go into it trying to change their mind. Maybe the first step is hearing people out, hearing where they're coming from, trying to understand how they arrive at that. And then, maybe there's a chance down the line to offer your perspectives and possibly change their mind. But I think the first step has to be hearing people out.
I think that is a wonderful note to close on. I want to thank you again for all the information that you provided, Dr. Jaiswal. And I definitely think listening is something we can all do better in our everyday lives. And starting with listening to each of you as panelists speak with us and how we can be a part of the conversation. Listening is a big part of that. So I want to thank you for just joining us today and answering the questions that we had from our guests. At this time, I am going to transition to our next panelist, Aaron Schwid, who's an international human rights attorney and the director of public health law at Vital Strategies. Again, I will mention this. Feel free to drop questions in the chat for our panelists. And at this time, I'll turn it over to you, Aaron.
Thank you so much. And again, I'm really honored to be here today. I'm grateful for the invitation, Imoni and Eileen, and I'm really humbled to be on a panel with Jessica and Yael. I'm really impressed by all your thought leadership here. And also to our keynote speaker, Jimmy Obayanju. It's thrilled to have you as a fellow GW grad. I'm just blown away by the work you're doing, and it's exciting it's really wonderful to hear all about it. So I'm the Director of Public Health Law at Vital Strategies. We're a global public health organization. We work with governments all around the world to help them develop strong and effective public health systems. And my job as part of that is to really focus on the legislative and regulatory frameworks around those that help them be successful. Over my career, I've worked in probably 80 countries or more, really working side by side with departments of health and other government officials to design these legal structures, both on questions on how to deal with epidemics in particular, but also other public health issues. We focus on tobacco and nutrition, road safety and air quality, reproductive health, lead poisoning, and even just the collection of health statistics, which is so crucial for policy setting. Say at the outset, these statements are my own, not on behalf of Vital Strategies. And on a topic of misinformation, I should say that there's a really good chance I say something inaccurate. So I please encourage you to push back, challenge me. I will correct it if I have done something wrong. That's my commitment to you. We started this work on epidemic prevention prior to COVID, and it was focused on countries' compliance with international health regulations and kind of the health systems building. But for obvious reasons, COVID has consumed most of my time for the past couple of years internationally. And before this, I didn't really work in the United States at all. The work was international, but I think one thing that came clear through COVID was how inadequate our own US systems were, and it made it impossible for any health organization to ignore. One thing that I love most about my job is that it sits at this intersection between law and policy, which I've studied in school, and the ability to make kind of massive public health change at a huge population level, but also thinking about this question of what's called kind of behavioral economics. And really it's this question of how do you get people to change their behavior? How do you get people to change their mind? So as a first question for you, hoping to make this a little interactive, but I'm not sure you can use the chat fully. I'd love you to think about when was the last time you realized you were wrong about a fact and that you needed to change your mind, and think about who convinced you to change your mind and what specifically did they do? What techniques did they use? What was their manner like? What did they do to get you to change your mind? And also think of the flip side. Has anyone ever tried to get you to change your mind and it just fell flat or backfired? What did they do that didn't work? I'd love to see in the chat, if you can, put some examples, not so much of what the issue was or the fact, but what are those techniques that worked or didn't work in this sense. The topic today is about misinformation and how do we combat it. And I think one thing that it's hard for us to keep in mind is that this is such a new instance. We have this novel virus. We're applying new interventions that have never been really done before. I don't know if any of you had heard of social distancing really before the last couple of years. The idea of being forced to wear a mask. These are all kind of new concepts. And kind of naturally as part of the rapid, just incredibly rapid development around this, there was going to be things that we got wrong. And part of the scientific method is this idea that you posit theories, you test them, and based on evidence, you reject them. And public health officials have this responsibility to make really quick, important decisions based on the best information they have at time. And the result, and I think Jessica got into this in great detail, is that the situation changes, and for people on the ground, you're getting what feels like conflicting messages as the situation evolves. And this really sets the stage for a problematic situation for misinformation. The mask example she gave was perfect. You know, at the beginning, there was a serious shortage of N95 masks and real concerns about hoarding, and that they wouldn't be available for health workers. So there's a recommendation that people shouldn't wear a mask. It made perfect sense at the time. But as the supply of masks improved, as we got more PPEs, and we learned how effective homemade masks were relatively, as the virus spread to more people, the guidance changed. Now, there's a perfectly logical reason for that change, but it leads to real tension. And so what I'd like to structure my presentation around are some of these tensions that we have to deal with as public health officials, and how do we balance them? I don't have any answers to these questions, but I just what we need is really smart, dedicated, well-meaning people to feel these tensions and try to explore how do you walk the tightrope between them and find a balance that works. So we're facing an infodemic, it's called, this just barrage of misinformation at a pace and scale like we've never really seen before. There have been conspiracy theories before, you know, who killed JFK? Was 9/11 an inside job? Was the election fraudulent? You know, these are serious conspiracy theories, but in a situation like COVID, I feel the stakes are higher. We've got this extremely infectious, unknown pathogen, rapidly changing situation, and we absolutely need people to comply quickly and completely with the government orders, or they put themselves and others at immediate risk. And as more people fail to comply, that risk actually goes up exponentially. Now, at the same time, you've got misinformation out there which undermines public health. It creates confusion and panic. It puts health workers at risk. And it's not just COVID, all public health deals with this. There was a recent study that found that of the most popular articles posted on social media about the 4 most common cancers, 1 out of every 3 contained false, inaccurate, or misleading information. So there's a real duty of the government to stomp this out, to get people to comply quickly. On the other hand, we have these human rights considerations. The Universal Declaration of Human Rights protects our freedom of expression, as does our Constitution. Kind of internationally, there's the International Covenant on Civil and Political Rights, says everyone has freedom of expression. There are regional, national human rights protections. And what that means is you have a right to hold opinions, to express those viewpoints, to access information, and to receive information through all media. And that includes the right to hold opinions that are wrong, that are misinformed. The law doesn't protect commercial fraud or defamation or hate speech intended to incite violent behavior, or things like incitement of war. And the governments can put in protections if it's necessary for national security or things like public health. But there's a high burden on governments doing this. So we've got this huge tension between this fundamental right to believe what you want, to speech, to expression, against the community's right and individual right to health. And in the situation like this, they really bash up against each other. So as part of my work, I explored some different ways that governments have tried to tackle this problem. Some take a really extreme route and just criminalize expression straight out. They'll prosecute people if they feel like they have stated misstatements. So that can include journalists, scientists, whistleblowers, or other kind of people doing purposely producing misinformation or disinformation. People have lost their jobs over this. Many countries actually passed emergency decrees criminalizing acts of kind of fake news. So Bolivia, Botswana, Hungary, Zimbabwe, Philippines, many actually passed laws, some of which included imprisonment up to 20 years for fake news or for misinforming or generating uncertainty to the population. So that's kind of one extreme. taking it a little step back, another step you can take, and I think one of the questions was, well, could you just restrict access to the misinformation? Are there other tools the government has to block or censor or hold speakers accountable for this misinformation? Is there a filter that you can put on to block this stuff? What's tricky is the problem with both the criminalization and this restricting is it depends on the government being the official source of the true information. They become the arbiter of truth and the whole truth. And sometimes that's not how it works. Sometimes there's good information that the public or journalists or others need to produce. This thing started because Dr. Wenliang in Wuhan was actually forbidden by the Chinese government for speaking out about his kind of discovery about COVID, and it spiraled out of there. We can unpack that in different ways, but that censorship actually became a real problem for this work. So another technique is that we see, unfortunately, especially in governments where they become the arbiter of truth, is they can end up disseminating disinformation or misinformation themselves. There are so many examples from this around the world, everything from the president of Madagascar endorsing an herbal tea as a cure for COVID and requiring all public school children to drink it, donating it to other countries, to our president here at home promoting hydroxychloroquine and other treatments that had no scientific evidence. And if you want to flame a conspiracy, you just take a little bit of kind of official misinformation and mix that with government attacks or censorship on other speakers, and you've just created just a perfect environment for conspiracy to grow. Now, that's not saying I don't think there are legitimate things the government can do. We've got a real problem with people who are purposely putting out disinformation or profiting from snake oil and other fake products. We've got for-profit news organizations that profit from conspiracy and outrage. And so there are consumer protection and other laws designed to address these kind of fraudulent products and marketing claims, but it's a very thin line between commercial fraud and the type of protected speech that's out there. The kind of final technique we've seen governments do is really taking an effort to disseminate as much accurate information as they can. This can do everything from Taiwan set up a fact-check center that people could submit information and get a response within 60 minutes on whether it was true or not, and immediately clarify the message to the public. In Ethiopia, they set up a hotline that did something similar, and really help people get out that message. You see daily press briefings. This type of work is so important and really hard. The other part of the work is teaching people how to be better consumers of information. The UK launched a digital literacy campaign or media literacy campaign called Share, where they encourage people to think about before they shared a social media post, did they think it was from a reliable source, so S? Had they read past the headline, H? Had they actually analyzed the article and thought it, made any coherent sense? That's the A. R, was it retouched? Does it feel like it was, someone had been playing with the article? And then E, are there errors? Is it, are there grammatical errors? Is it just basic things missing that make you think this isn't a reliable source? Before you share and spread out the misinformation, think about these things. So that's one tension. The second tension is this pull between what we call the precautionary principle in public health and another principle, which is that public health measures should be the least burdensome alternative. And the precautionary principle is this idea that when there's a health event or a health risk, the government should be able to take measures that are precautionary, that might be eventually seen to be too broad, but are so important to protect health that they can take these precautionary steps. The other principle is this idea that the government should only do things that infringe on rights if they're the least burdensome alternative. And when I think about how we deal with misinformation is, what is the government's response to it? And how do we think about punishing people, if at all, when they are arbiters of this misinformation? And the approach we take is that no sanction should ever be imposed unless the compliance is absolutely necessary. The sanction is actually proved to be effective. Does sanctioning the person actually achieve the public health objective you're trying to do? Were there other options available that were maybe least burdensome? And are you applying the sanctions in a way that's actually equitable and transparent? If not, if you can't meet those standards, you should look at other systems improvements, education, social and medical support, incentives, other tools that we have to do this. And this worry about sanctions in public health really came to light for me in a deep sense in 2014 with the murder of Eric Gardner. I was working on tobacco control legislation worldwide at the time. And if you remember, the reason the police interaction started in the beginning was because he was selling cigarettes without a license on the street. And I work with countries all around the world, helping them put in legislation to require a license to sell cigarettes and to make laws against selling loosey cigarettes because they're more easy for kids to buy. And it's devastating to see a policy that is designed to save lives being twisted and used for brutality, extrajudicial killing, murder, and honestly, it really shook me to my core. So we've been really trying to think about how do we take public health and make sure that any of the powerful government tools that we have at our disposal are used effectively and equitably, and in no way cause these kind of unintended consequences that we're really afraid of. So I guess I ask you again, if you haven't had a chance to put in the chat, what helped you change your mind about something, thinking about this, and is the threat of punishment an effective tool or not? If not, what are other things that are more effective? Just conscious of the time, how much more time do you want to go? Okay, I'll keep going. You just cut me off when it's time. So the third tension that I've really noticed, and I don't have a real answer to it, is this the public health interest and the role of a free press. And I believe that a vibrant free press holds governments accountable, and we absolutely don't want to do anything to stop the government's ability to allow the government to quash of the free press. On the other hand, our media environment is such that it's, again, corporate owned, often profit driven. It thrives off conspiracy and outrage, and there's no or almost no accountability when they cross the line and perpetuate misinformation. One of the interesting cases that have recently come out is the Dominion voting case, where they sued Newsmax for defamation about saying that there was fraud in the election. I think this is a really interesting example of how we might see this interplay play out in the future between using a private right of action to hold media accountable for spouting lies. Now, I'm not 100% convinced our courts and juries are the best arbiters of truth in all these cases, and there's plenty of problems with that. I'm not sure the judiciary is necessarily better placed than legislators or regulators to determine, fact from fiction. But the challenge is, what are our other alternatives at this point when a free press chooses to use their power to spout untruths? Another discipline or another tension that we really deal with in the public health community, thinking about government control of the information. Now, during something like a pandemic, when you need to have strict discipline about the messages that you're distributing to the public, you basically have to set up like an emergency military type operation going 24/7, reading all the new studies and guidelines that are coming in, issuing new orders, trying to make your message as crystal clear as possible to the public, in kind of sound bites that they can clearly understand. This is an art, it's a science, it's a totally thankless job. But for it to really work, you really need discipline, and any official talking off message screws up the whole operation. It muddies the water and it creates real confusion at a time when it's crucial. At the same time, in a democracy, we absolutely need devil's advocates within the system. We need those naysayers. We need people to challenge the authority. It's important to prevent groupthink and improves the overall result. So how does this work out in reality? You create a safe space, maybe internally within the Department of Health, where people can debate and argue, and then have maybe a united front externally. But what becomes, again, problematic in this democratic sense is people feel like they deserve total transparency about what's going on within the functioning of the government. They think they deserve total transparency to the process and the debates that are happening, not just the ultimate conclusions. I'm really sympathetic to that argument. At the same time, again, it muddies the water when you see that. So how do we resolve that tension that is so difficult during an emergency? I guess the final tension I'd like to talk about is between beliefs and actions. Do we, as public health officials, at the end of the day, really care what misinformation people believe, as long as they're acting in the way that they want? People might think if I wear a seatbelt, it's gonna create injuries in my abdomen, and if I fall in the water, I'm not going to be able to get out. You might think it's risky and it's not worth it, but at the end of the day, if you're wearing your seatbelt, because then it's working. From a public health perspective, it's hard to know what's more important: people doing the right thing, or just following your instructions. We're at the point in this pandemic where it's so crucial that people get vaccinated. And we're inching closer to a vaccine mandate, kind of step by step. And there's real questions about where does belief fit within this mandate? Should people be able to use religious exemptions or other deeply held beliefs as a reason to get out of these actions? And how far should the government mandate go? Is it too much of a reach to tell you can't work at a job, or go to school, or go to a restaurant or a concert? Where's this line that's proportionate to the effect that we need? I think another part of that question that's so crucial, and this has come up over and over in today's discussion, is thinking about how will things like these mandates affect communities that are already rampant with misinformation. Is this going to work as we want, or is it going to backfire and just perpetuate more of the discrimination and disparities that are already there? One of the biggest challenge, I think, from a public health perspective is, no matter how well-meaning and how much science backs up what we're trying to do, there's always a hint of kind of nanny state, we know better than you, paternalism, in the international space, colonialism, when these orders and instructions are coming from on high. So making sure that the communities you're working with you're bringing them along, you're listening to them, bringing them on, is the only way to make this work long term. So quickly, just a couple solutions I'd like to propose to help this. First, I think at the very least, we need to acknowledge these tensions exist and discuss them opening. This forum and others are really great opportunities to unpack some of these challenges. I really can't stress the importance of risk communications and funding those departments and training them enough. They're often an afterthought. Public health in general is underfunded, and this department in particular has a thankless job that needs to be raised up. We need creative minds to think about new techniques to help dispel misinformation. There's no golden ticket. I think punishment is lazy. There's got to be better tools out there to tackle this problem, but we need creative, innovative thinkers to help us out. And kind of finally, I think we need to get out of headquarters and get into the community. We've heard this over and over again, but you need to listen to people's concerns, really understand them and address them in a meaningful way. We can't dismiss people no matter how much we disagree with them or how much the science disagrees with them. So looping back to how today started, there was an urgent call to action saying we've got a lot of work to do. I can't emphasize that enough. I really hope to encourage all of you to pitch into this area of work. Public health needs you, the legal world needs you. Your superpower is your ability to change people's minds, and the world needs that now more than ever. If you have any interest in a career in this field, please reach out to me. I'd love to talk to you about opportunities to work in this place. And thank you again.
Thank you so much, Aaron. Yet another informative presentation. I don't know about everyone else, but I am personally walking away with a lot of information. We have one question from an audience member who said, how far should the government go with vaccine mandates? Do you think the pandemic will continue to worsen if vaccine or mask mandates aren't put in place further?
Look, I don't know how I've given up predicting the future with this epidemic. It's a fool's exercise at this point. I think the only way we can do it is the kind of ratchet technique. We gotta increase the mandates a little bit, see how it goes, increase it again if necessary, and try to take other techniques to encourage people to be vaccinated. I really believe we want to take the least restrictive path to that and try to bring people along. But if the rates of death stay where they are, we really have no choice but to kind of up it slowly until we can get this thing under control.
Thank you. For you personally, I know we discussed how to be better consumers of information, but I wanted to ask each and every one of you, our panelists, before we close for the day, with a panel discussion about health disparities during a time that many of us have never lived through something like this, how do you, one, advise the audience members, some of whom are your colleagues, others who are students, to navigate kind of with mental health needs in tackling health disparities in your professions? I guess we'll start off with you, Aaron, and then we'll jump over to Yael and Jessica.
Sorry, the mental health needs of themselves or kind of the broader community? Whew. Oh man, I wish I had an answer for that. We've all been going through it. I think as activists, as people who work in any space, you're going to find a balance between taking care of yourself and taking care of others. And when you feel like it's your time to go out and fight the good fight, and you've got the support to do so, that's your time to do it. If you need to go back and kind of lick your wounds and take care of yourself, that's part of this work as well. So you can't help other people if you're not in a good spot. So.
Yes, agreed. Thank you. And I'm curious to hear each of your thoughts, because you all are approaching the health disparities that we see from many different angles and different work. Jessica, I would like to hear your thoughts as well.
I think along similar lines, what's the saying, like you can't pour from an empty cup type scenario. At the same time, like I know that when I take a break, it's because I have the privilege to do so, that I can like step away in some ways. So I think for folks that are community-based or living in a particular community, so for me, much of this, not all, is academic. So, just acknowledging that it is a privilege to step away. But even if people are in the thick of it, I still think the advice to refill your cup when possible and to take a break is still, absolutely the right advice.
And I think, for Yael, I'm curious to hear, as a supervisor, both with the Health Justice Alliance and with the clinic, how are you as a supervisor encouraging your colleagues to support individuals with their own mental health in this work?
Yeah, that's such a great question. I think that especially now where much of our time, even right now on this panel, is scattered, it's really, really important to find ways to build community and to come together in community. And so for our med and law students, I mean, we have these med students who are coming off of emergency medicine rotations and really, really intense work in the hospitals, and then coming over to our law clinic and working on you know, issues for really, really high needs populations where, you know, maybe whether a family stays housed is in our hands, and it's a lot of pressure. But we work really hard to build community among our students and to feel community with those that we serve, and to try to draw you know, try to draw energy and inspiration from that. And so I also just wanted to end by saying thank you, Imani, because I think you did a wonderful job
Yes.
throughout this panel of just creating community, even though we are scattered in this way. And I hope we'll have other opportunities in the future to be in community together.
Well, thank you all for your time. I appreciate the compliments, and truly just wanted to take the opportunity to say I am wildly in awe of all that you are doing, that you continue to do for various communities, especially during a time when this is as tasking on any person that you'll turn and look to. And with that, I would like to thank you for helping us navigate misinformation and distrust, and thank the Ms. Santos and Jeremy and all the individuals who played a role in putting today's events together on this 20th anniversary. So I want to thank each of our guests, each of our panelists, and hope that you all have a wonderful rest of your day.
Thank you.
Thank you, everyone.